Hello, class. Welcome to Lesson 8 of Medical Care Organizations. I am your teacher, Professor Hussein. Okay, today's lesson 8, is so long. It's probably the longest of all the chapters. So I want to try to make this not very long, but I don't also want to skip out on information that's going to be very important. So let me do the best that I possibly can. Normally, this particular chapter will take me 2 whole days. So let's try not to let it get that far, but let's see. So anyway, what we're going to be looking at today is inpatient facilities and services. I know that you're probably thinking, well, we just studied outpatient the other day and it looks like everything's going outpatient. Why do we care so much about inpatient? This particular chapter, yeah, we're going to kind of look at like inpatient services and whatnot, not so much focused on the utilization of inpatient services, but we're going to look at a lot about what a hospital is, who runs a hospital, who's in charge of a hospital, how we can categorize different hospitals, okay, how they all kind of are organized and categorized in this country. Okay, so let's move forward. First of all, inpatient. Inpatient means that you're staying overnight in a healthcare facility. So I think we already went through this before. You stay overnight in a hospital or any kind of healthcare facility. That makes you an inpatient. Okay, that's what inpatient means. All right, so that's just a big concept behind inpatient. Next, hospital. What are the requirements? If I want to be a hospital or I want to open up a hospital, what are the main things we have to worry about? So first of all, every hospital, in order to be a hospital, you have to have at least 6 beds, okay? That's the minimum amount. Yes, there are hospitals that small in this country that are out there. Many hospitals that we're probably used to are a lot larger than that. Even the small hospitals that we're used to are larger than that, but let's move on. Okay. So you got to have at least 6 beds to be a hospital. You also have to be licensed by the state, okay? You have to have an organized physician staff, so you got to have your hospitalists working in the hospital. And a lot of what that is just for the formality or the documentation, just knowing you have physicians in there, running the place and overseeing everything going on. Okay, of course, they're definitely going to see patients and they're going to, work in it, but for the most part, they might not be full-time working in there. You might have a contract with physicians. They might be like independent contractors. It might be that kind of a situation, or you may actually hire the physicians like on a salary, like they're your actual employees. It could be either or. There are actually a lot of different ways you could work with physicians. Just contracting and then hiring as an employee are just 2 ways, but there are a lot more ways that you can work with physicians and different types of employment statuses and whatnot that you can have going on with them. Anyway, let's move forward. So you also have to have continuing nursing services 24/7. Okay. All right. So what else do you have to have in order to have a hospital? So you have to have all your construction and operational stuff taken care of. So a lot of this is stuff, these are like federal laws and also city and state laws, like requirements as well. So a lot of this is going to have to do with like health regulations, fire codes, whatever policies the city has, all this. A lot of it's just bureaucracy, a lot of it's just paperwork and things like that, but then there are certain standards that you do have to abide by within the construction and operations part of opening up a hospital. I mean, a lot of this is just like, this is going to be standard pretty much across the United States. Maybe not every single city is going to have exactly the same requirements. Some may be more stringent than others, but for the most part, this is pretty standard. Just follow all these normal hospital business, construction and operations procedures. And then, so what else do you need to open up a hospital? Every single hospital has to have some sort of governing body. So that is legally responsible for what the hospital does, the operations of the hospital and whatnot. So this would be like a hospital board, your board of directors and whatnot, right? Then you have to have a CEO that is actually the guy or the girl, like that one person that's responsible for overseeing the operations of the whole operation. Okay, then you also have to make sure that you have medical records for each patient. You have to make sure there are pharmacy services for all your patients. Okay, and this has to be supervised by an actual pharmacist that is working there in your hospital. And then you also have to have food services. Okay, you have to be feeding your patients. You don't necessarily have to have a full cafeteria for all your guests as well, but you definitely have to have food services available for your patients because they're staying overnight, you gotta feed them. Okay. Okay, so hospitals consume the largest share of national health spending. So much money. Okay, and this is the main reason why they were the first to be targeted when Medicare decided to go through that shift in reimbursement. They went after the hospitals first. Okay, because they're taking a lot of the money. It wasn't like the small little solo practice physician that wasn't really the problem. It's hospitals. Okay, they are taking most of the money. Okay, most of the Medicare money and whatnot. So that's why Medicare targeted going after them first with the new prospective payment system before everyone else. So PPS, just to let everybody know, let me get a brighter color so it stands out more. Okay, so PPS stands for Prospective Payment System. Okay, prospective payment system. That is the payment system that Medicare decided to change everything over to. Okay, going from cost plus to prospective, the prospective payment system, or PPS. Okay. Go. Okay, so over the years, hospitals have transformed. There's kind of like a different level of like evolution that hospitals have gone through over the years since the US even became a country and we had healthcare. Okay, so in the beginning, we'll start from over here because then it starts to evolve and then we go down to like over here, right, where we are now. So in the beginning, remember we looked at back when we looked at the pre-industrial era? That was pre-industrial era. This is this, okay? So pre-industrial era. This would be the beginning of the post-industrial era. And then it just gets more and more complex and they just add more and more to the health system. So in the very beginning, remember, in the pre-industrial era, we had almshouses, pest houses, we had asylums, dispensaries, and those were the different medical facilities that we had, right? And a lot of what this was, it wasn't necessarily a place for learning or for, to teach new physicians. They weren't a place of medical technology and advanced treatments or anything like that. Back then, it was all just about social welfare. It was like, let's just take care of those who are needy, those who are sick. And that was really it. We don't necessarily treat them. Medical science hadn't gone too far at that point, so that's really all it was. Then as we started to come out of that and we started to incorporate more medical science, more science into our medical practices and all that, and then we started to really remember in the beginning of the post-industrial era, we started to actually rely on physicians more, because we started to get more sick, we started to get our communicable diseases, we started to get our workplace injuries, and all that was happening. So we started to rely more on physicians, and we started to really believe in science a little bit during that time. Remember? So at that point, as we start to progress, it became about caring for the sick, offering some sort of treatment for the patients, okay, whatever we had. And then it started to grow. Okay, so we started to actually really develop this medical science and technology, and we started to have antibiotics and x-rays, and so we came up with machines, we came up with sterile techniques, we came up with anesthesia for surgery and things like that. So medical practice started to be more grounded in medical science, technology. We started to create larger hospitals, and there was more organization in the hospitals. Hospitals started to have administrators now. Okay, they started to have other staff keeping record of the patients and all of that, right? Because we didn't have this kind of thing back then, way before. So we started to really let's start to organize healthcare. Okay, then we started to focus a lot on medical training and research, and so we redid the whole medical education in our country, and we focused a lot on research and development and trying to get everyone to become specialists, and we started coming out with all this new medical technology, and we really developed our teaching hospitals. Okay, the teaching hospitals are where medical research and innovation and all the unusual illnesses, diseases are taken care of. Okay, it's usually the gigantic, huge research and training medical facilities. Okay, and then now we are coming into more of a consolidated system type of a situation. We're actually becoming more corporate these days. Okay, so we have multi-chain hospitals. It's not just one organization anymore. It's boom, 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 multi-chain hospitals, and organized by someone at the top, and just it's full of different levels. We've come up with managed care and other integrated care systems. So now it's we don't necessarily just have private health insurance. We have managed care organizations, integrated health systems and whatnot, where we have a whole system that really, when you're part of it, it incorporates all parts of a healthcare system within that organization or that system. So we don't have to it kind of centralizes all of it, so it condenses it all into one system. Okay, and that's what we did. That's why managed care organizations have become so common. Okay, because they really took all aspects of a healthcare system and they put it under one umbrella. Okay, so they really consolidated the healthcare system and how a healthcare system should function, or how they believe it should function, and they cover everything within that medical care organization. Okay, so they'll act as the insurance company, and they will provide the providers for all the different levels of services that you need, and then they have other stuff going on. They have a full spectrum of system and of different types of services and care that they provide under that whole system. Okay, so we have a lot of that happening as well, and that's what we have gone to. Okay. So, expansion of hospitals. There are 6 main factors for how or why the United States hospitals have really expanded. Okay, how we've grown from the pre-industrial era and just having a couple hospitals here and there to being to getting to where we are today. So there are 6 main factors of how it grew. Okay, we're going to go over each one of them. First, we have advances in medical science. Then we have the development of specialized technology and surgical services. Then we have advances in medical education. Then there's development of professional nursing, growth of health insurance, and then the role of the government. Okay, so these are 3 of those factors that have contributed to the growth or the expansion of hospitals in the United States. So first of all, we have the development of nursing. Okay, it was somewhat transformed after the Crimean War by Florence Nightingale. Now, Florence Nightingale was she was a manager and she was a statistician at the when all this war was happening. And what she actually did was she organized care, okay, for the wounded soldiers, and eventually that led to her changing the way that nurse education is done and whatnot. So she noticed a lot of, I guess, problems within the way that care was being provided, and she found the flaws, and she realized that we have to make a change and nurses need to be educated. So nurses became educated. And their treatments have become way more efficient. They practice great hygiene and all of that kind of stuff. And it's since nursing is really the backbone of our healthcare system, of healthcare in general, just getting our nurses educated and being able to practice so well really expanded hospitals, okay? Because now hospitals are way more efficient. Okay, hospitals are out there saving lives, and people start depending more on hospitals to provide the best care. It's because the nurses are able to provide that care. Okay, so then we have the growth of health insurance. Growth of health insurance started to happen really after, like, in the late 1920s. Okay, that's when health insurance or private health insurance really started to spring up, and then it started to eventually spread. And health insurance, as soon as people were able to have the opportunity to purchase health insurance, then that provided them access to all this expensive medical care. So suddenly they were able to use the hospitals and all the cool care that they were able to provide whenever you're sick or injured. Okay, so that created the need for more hospitals to be made. Okay, then we have the role of the government. So the government, back in like the 30s and 40s and whatnot, they realized that we have a severe problem, especially after the Great Depression. Because during the Great Depression, so many hospitals were closed. We had no money to keep them up. So a lot of hospitals, they couldn't keep a business and they had to shut down. So we had a lot of hospitals shutting down, few were still running, and the government was like, we can't do this. We can't move forward as a nation if we don't have enough hospitals. So what the government did was it came up with the Hill-Burton Act of 1946. So this Hill-Burton Act, what it did was the federal government, they issued grants. They just had money out there, and they gave grants to nonprofit community hospitals for them, or for nonprofit organizations to build community hospitals, okay, all over the country, because there was a certain ratio, like population to hospital bed ratio that we were trying to reach, that we needed to achieve in order to be able to feel like we're able to keep our country safe and taken care of health-wise. right? So they came up with the Hill-Burton Act, and that is what gave money to various different nonprofit organizations so that they can build hospitals. Now, this whole hospital building and hospital expansion thing that the government was trying to push for really wasn't, it didn't happen overnight. It took 34 years for us to actually reach our goal, okay? So by 1980, we finally reached the goal of having 4.5 beds per 1,000 population, okay, right here. So finally, we got to the point where we were okay. Okay, we got enough hospitals in all the different areas, so there's enough hospital beds and medical care for whenever we have emergencies and when it's necessary. Okay. Now, so in the 1980s, okay, so that was all the whole expansion of hospitals, right? Hospitals growing and us having so many more hospitals. Well, in the 1980s, we actually started downsizing. We started losing hospitals, okay? So why did we start losing hospitals? Well, it all comes down to that thing, that one thing that keeps showing up that really changed our healthcare system, okay, in the 80s. Do you guys remember what that thing is? What that event, that thing that happened? I'll wait. Do you remember? I'm just kidding, I'll tell you. Okay, so it was that whole change in reimbursement, okay? Remember, we went from cost plus to prospective payment system, and when that happened, a lot of hospitals couldn't handle it, okay, because they weren't able to make the money that they were used to making with Medicare, okay? So a lot of hospitals closed down. A lot of hospitals struggled like crazy to stay afloat, and many closed down. Many of the hospitals that urban and rural, but a lot of the hospitals that suffered and still suffered to this day are the rural hospitals, okay? So definitely increased utilization in the hospital, decreased the utilization in the hospitals, and those hospitals who weren't able to change their focus over to outpatient instead of inpatient, they closed down, okay? So it definitely created incentives for us to decrease our inpatient utilization in the hospitals, okay, when this change happened. Now, of course, remember I said in the last lesson that managed care also impacted these hospitals, okay, during this time. Because managed care, because managed care took advantage of like a lot of the problems that employers were facing and the people of this time were facing, and then hospitals going, oh no, we're losing money and all that. Managed care took advantage. So managed care got a whole bunch of beneficiaries, a whole bunch of patients, because they got the employers to buy into what they were all about, okay? So then they got a bunch of beneficiaries and they had contracts with the hospitals. Of course, hospitals were desperate just as much as everyone else to have patients because they needed to make money. So hospitals were definitely willing to sign contracts with managed care so that they can take on their patients. But guess what? Managed care is all about cost containment. Remember I said that's their favorite thing in the whole world. They love saving money. They love reducing utilization and making sure they don't have to pay anyone that much, okay? So managed care focused so much on cost containment that they wouldn't even allow a lot of utilization of these hospitals. And so they tried to push a lot of focus on outpatient as well. So they didn't use as much, they didn't really approve of very much inpatient utilization, Okay, so that's another reason why a lot of hospitals were also hurting, because they weren't having enough people or enough patients that would pay them enough, and use their hospital services. Okay. All right. Okay, so now we're going to look at utilization patterns. So who's using the hospital the most? Well, first of all, the elderly. Let's not call them elderly. Let's say older adults. Okay. So older adults probably have the highest amount of utilization in hospitals. But we probably already knew that. I feel like that's kind of obvious. Same thing with children under 1 year of age. At that point, they're very vulnerable. Their immune systems probably haven't really taken off yet. So yeah, children under 1 year of age are also immunocompromised. They might be pretty susceptible to a lot of things. Women have higher utilization rates as well, but it kind of makes sense because there's a lot of, of course, there's women's health, there's labor and delivery, there are a lot of things like that. Plus, given the fact that women typically will go in to get services, if they think something's wrong with them, they're going to go to have it checked out. Okay, women tend to do things like that. Okay, they'll use their health care, where compared to men, not all men, it doesn't necessarily mean everyone, but statistically men are less likely to go use hospital services or anything like that if they feel like something's wrong. If they think that they can, I don't know, handle it or tough it out, I guess they're going to. And sometimes it gets, they'll allow things to get so bad, and then finally they'll go to the hospital or something. So we'll see a lot of usage of the hospital with women, but not necessarily men, because they don't want to use the hospital if they don't need it, I guess. And they try to never need it because they're tough. Anyway. Also, there are higher utilization patterns among people of lower socioeconomic status. Now, there might be a huge reason behind that, and it's not the only reason, but one thing that we should not forget is that the hospital, the ER department in the hospital is required. They have to, by law, care for you whether or not you have an ability to pay. So if you come in there with an emergency, they have to take care of you. Their job is to make sure you are stabilized. Now, after you're stable, they can, kick you out. But they have to make sure that you are stabilized regardless of your ability to pay. So if you don't have any ability to pay, yeah, they're still going to take care of you. They're going to still do whatever they need to do for you. So you see a lot of people lower socioeconomic status, meaning people who probably don't have health insurance, and things like that, go in. They might wait until the problem is really bad, and then they'll go into the ER, get their services and whatnot, and then they'll have, and then that's it. And the thing is that this doesn't necessarily mean that the ER is like a free clinic, because they're still going to hold you responsible for the cost. It just means that they're going to take care of you for now until you're stable, and then they're still going to send you your bill. They're still going to have collectors come after you. Now, it's your choice if you're going to pay it or not, of course, but what my point is that they're not going to say, oh, you don't have insurance or you don't have money, that's fine, we're not going to save your life. Go. No. You get taken care of, and then you can worry about how you're going to pay for it, or if you're going to pay for it later on. Okay, so that's the deal there. That's how that works, really. Also, there are higher utilization patterns among people who are both Medicare and Medicaid beneficiaries. And of course, Medicare, the people who are beneficiaries of Medicare are who? those who are 65 and older, the older adults, right? And then also, those who have Medicare are usually disabled or have end-stage renal disease, which would kind of probably explain why there are going to definitely be higher utilization patterns of hospitals among those groups. Okay, that I think we would expect that. Same thing with Medicaid beneficiaries, because most Medicaid beneficiaries, well, are going to fit into the lower socioeconomic status. They are also, many Medicaid beneficiaries are also Medicare beneficiaries as well. Okay, so if you're a dual beneficiary, then I mean you're probably, that might mean that you are of lower socioeconomic status and you're an older adult. Okay, also you have a disability, so you're not working, so of course you're going to have Medicare, but you qualify for Medicaid as well, and things like that. So, all right, let's move on. So here are a few things that we need to know. Just a few terms and things like that we're gonna go over real quick. And this is how we sort of like measure utilization in a hospital. Okay, so discharges. First of all, what is a discharge? That's when you're done getting your treatment, or you're done staying at the hospital, they're done, and they just sign you off and you're ready to go. You're done with your service. So that's a discharge. That's when you get to leave the hospital. What is an inpatient day? An inpatient day is actually measured by how many nights you spend as a patient in the hospital. Okay, it's not days, it's nights. Okay, so what this means is that, like, let's say if I checked in, wasn't admitted into a hospital at, like, let's say 3 p.m. on Monday, and then I was discharged at 3 p.m. on Wednesday, does that mean I stayed in the hospital for 3 days? I had 3 inpatient days? Or no, it would be that I have 2 inpatient days, okay? Because you count the nights, you don't count the days. We count the nights that you spent. Because remember how what we call inpatients? Those are when you stay overnight in a hospital, overnight in a healthcare facility. So that's why we count the nights. So if I was checked in at 3 p.m. on Monday and I left 3 p.m. on Wednesday, yeah, okay, those technically like 3 days, but how many nights was I there? I was there for 2 nights. Okay, so only that would give me 2 inpatient days. Okay. So next one, let's look at days of care. So days of care, this is just the cumulative number of patient days over a certain time period. Okay, over a specific time period, all the different patient days. Okay. Next, we're going to look at the average length of stay, or ALOS. Okay, so the average length of stay can be calculated by the days of care, okay, divided by the discharges. So all the different days of care, maybe in a specific department, you can look at all the different days of care, all the different amounts of days inpatient days that you had patients staying in your department for a certain period of time, so maybe like for 1 week, okay, and then divide that by how many discharges you've had, and then that will give you the average length of stay, okay, which basically will yield a certain amount of days, and we'll call that the average length of stay. Next is the capacity. Okay, so capacity is This is how many beds that are available in the hospital that are just set up and ready to go. Like they are staffed, there's electricity happening there, they're cleaned, they're available and, you know, just open for business. Okay, so usually in a hospital, not every single bed is ready to go. Many times hospitals might just kind of close the lights and shut down certain sections of the hospital because they're not trying to use those. Maybe they normally don't have a high enough volume to really keep that stuff open and staffed, so they might just shut certain areas down in a hospital, and maybe they only open them up when there is the need for it. Okay, so but what capacity is the amount of beds that are set up and staffed and ready to go and, you know, ready to put patients in. Okay. Then we have our average daily census. So the average daily census is the average amount of beds that are occupied on a daily basis. Okay. Okay, so the occupancy rate is the percentage of the capacity that is occupied. Okay, so of all those beds that are available to be used, the occupancy rate is the amount or the percentage of those beds that actually have patients in them. Okay, so what you're gonna do is you divide your average daily census by the capacity and multiply that by 100. Okay, well, it's all right here. Right there. That's all you need. Anyway, so these are some trends of hospital utilization and employment. So I'm going to allow you to go ahead and read through those. It's just some really cool, interesting stuff about hospital utilization and employment. Go ahead and look it on yourself. Let's move on. Okay. So this can also help put things into perspective a little bit. Okay, so these are hospital costs. Hospital costs are so expensive. Hospital stays are really expensive as an inpatient. Okay, in 2010, which obviously it's way more expensive now. This is a decade ago. You think prices have dropped? No, they always increase. Okay, so in 10 years ago, the average cost per stay was $9,700. Okay, so expensive. This is, so anyway, and on average, people might stay maybe 2 nights a week or 3 nights a week. So it's just around that general, like, around that time. That's basically like $3,000 a day. Can you imagine, like, staying in a hotel that expensive? No, you can't, or maybe you can. But I can't. And I mean, it's just crazy. Hospital costs are extremely expensive. Okay, I know my sister, when she had back surgery a couple years ago, and her surgery literally cost $40,000. Okay, she was only staying in the hospital for 5 days. $40,000 for the whole thing. Okay, so that's literally $8,000 a day. Okay, that's a lot of money. All right, so being an inpatient is crazy expensive, and this can kind of give you an idea and put things into perspective. If you like having more inpatients than outpatients is a nightmare, especially for a health administrator when you have bills to pay and you have to staff, you know, this, and you have labor that you have to calculate, and just it gets insane. So anyway, let's move on. Very expensive stuff. Okay, so now we're going to look at the different types of hospitals. But what I want to do is go ahead and allow a part 2. We've already taken up 40 minutes of your time, so I'm just going to close this out, and we'll pick up here in lesson 8, part 2.